So my name is Andy Davies from the University of Southampton, and it's great to be able to talk to you about the sequencing of treatment options for patients with primary refractory diffuse large B-cell lymphoma. So I have a number of conflicts of interest to declare. So we have a 72-year-old female who presents with weight loss, cervical lymphadenopathy, and inguinal lymphadenopathy. A biopsy demonstrates that she has diffuse large B-cell lymphoma, NOS, of a GCB phenotype with a high proliferative fraction. FISH analysis does not identify any translocations of MYC, BCL2, or BCL6, and there's no overexpression of MYC or BCL2 by immunohistochemistry, so she's not a double expressor. Interestingly, a mutation panel has been performed. This demonstrates a mutation in BCL2 and CREB-BP, which is a epigenetic regulator. The patient has nodal disease above and below the diaphragm on a PET scan, and she has bone marrow involvement. Her lactate dehydrogenase is elevated 4.5 times above the upper limit of normal. So she has stage 4B disease with a high IPI. 4 cycles of R-CHOP chemotherapy are given, but unfortunately, she has disease progression through this. Her bone marrow remains positive, and her lactate dehydrogenase is high. So I think, attainment of a complete response rate with R-CHOP chemotherapy is really important in determining cure of diffuse large B-cell lymphoma. We can see from clinical trials that about 80% of patients are alive and disease-free 2 to 3 years after completion of therapy. But in the real world, probably 40% of patients are failed by conventional R-CHOP chemotherapy, including a number of patients who present with primary refractory disease. We can identify using clinical prognostic scoring those patients who are going to do well and perhaps those patients who are going to do less well. And of course, we can refine the RIPI. And we also can add in prognostic information from the biology. So for those patients with double hit and double expressor lymphoma, perhaps they do less well. And perhaps those patients who have an activated B-cell phenotype also do less well than those patients with a GCB phenotype. It's really interesting how we're beginning to understand and exploit the molecular heterogeneity of diffuse large B-cell lymphoma. But we recognize that there are distinct subgroups with distinct patterns of oncogenic aberrations and pathways that are dysregulated, and that may be important for prognostication, and they may well be very important in the future for therapeutic targeting strategies, but we're not quite there yet. Our patient, because of the mutations in epigenetic related genes, falls into this group of the EZB group, but that doesn't influence anything that we do in terms of our therapeutic approach so far for this patient. So primary refractory disease, we've become used to this data from the SCHOLAR-1 study. And this identifies group of patients who have had 4 cycles of R-CHOP chemotherapy who have either stable disease or progressive disease, and they have poor outcomes. Their median overall survival is just 7.1 months. But we can subdivide primary refractory disease into different groups. And we can see from registry data that those patients who have primary progressive disease on chemotherapy or within short weeks after completion of primary progressive chemotherapy, of induction chemotherapy, their overall survival is poor, and it's less than 20% at 2 years. For those patients who are considered refractory by virtue of the fact that they have residual disease at the end of induction therapy, i.e. partial responses or stable disease, they have perhaps a better outlook with a 31% overall survival at 2 years. And for those patients who achieve a CR but relapse within 6 months of completion of induction immunochemotherapy, then they perhaps achieve even better outcomes, these early relapse patients who have a 2-year overall survival of some 46%. I think the way we think about primary refractory disease needs to change because we've lumped them together all in one group of patients who have relapsed and refractory disease, and we look at these all with the same treatment paradigms. And I think we perhaps should think about these different groups a bit better in the future. So what's our choice of therapy? Well, I think, we look at the fitness of the patient. For those patients who are clearly frail and have significant comorbidities, then we go down an approach of non-transplant eligibility. But for those patients who are fitter and younger, then the pathway is currently to have reinduction immunochemotherapy followed by stem cell transplantation consolidation after high-dose chemotherapy. And in the middle is this new group of patients who we consider to be borderline for stem cell transplantation or perhaps CAR T-cell fit, which I'd like to go on and talk about a little bit later during the presentation. So we can induce remissions in patients who are primary refractory to R-CHOP chemotherapy. We've seen from the REFINE study that doesn't really matter which reinduction chemotherapy you use. The outcomes with cytarabine-based regimens are the same as the outcomes with non-cytarabine-based regimens. We can see that response rates in patients who relapse within the first 6 months or are indeed primary refractory can be as high as 50%, with complete response rates in the low 20s. For those patients with truly primary refractory disease, the chances of responding to a second-line regimen are probably realistically in the order of about 30% or thereabouts. For those patients who do achieve a response to a second-line therapy, then there's a clear role for autologous stem cell transplantation. And actually, indeed, durable responses can be achieved, as we can see from the data from the CIBMTR. So we looked at patients, this study looked at patients who had a complete response or a partial response to a second-line therapy and then went on to have an autograft. 35% of the patients were in CR and they had a progression-free survivals of about 40% or thereabouts. And it didn't matter whether patients had had stable disease to induction therapy or progressive disease. If they achieved a response and they achieved a remission with second-line therapy, then long-term outcomes could be achieved with autologous stem cell transplantation. And we've seen data this year that demonstrates that you don't really need to have achieved a PET-defined complete response to benefit from an autograft to consolidate response. This data from CIBMTR looked at those patients who showed chemosensitivity but had residual PET positivity. So we're in PET PR. This is almost 250 patients. And for those patients who did have an autograft, the progression-free survival at 5 years was 41%, with an overall survival of 51%. Those patients who had early relapse fared less well in the first years after, but actually the curves eventually come together. So I think there is a role for autologous transplantation in those patients, even if they achieve a PET positive partial response. I don't think you need necessarily to get them to a complete response. What about the role of autologous stem cell transplantation in this patient who's 72? Well, we can see a number of sites have published data from those patients who are older undergoing stem cell transplantation. And you can see from these curves that actually we see durable responses in those patients over the age of 70. But you have to select your patients. So I think we're really careful about choosing patients who have the physiology to be able to withstand the rigors of sepsis and the physiological challenges of high-dose chemotherapy. And I think we clearly need to make sure we optimize our supportive care for these groups of patients, that we think about how we assess them before selecting them for transplantation. And I think what's really important is to think about their trajectory of functional recovery and their rehabilitation after stem cell transplantation. So deciding to undergo high-dose chemotherapy in older patients is a really individualized choice that requires shared decision-making between the patient and us as the physicians. So, of course, the therapeutic landscape in DLBCL has changed, and of course we have a number of approved CAR T-cell therapies for third-line therapy in diffuse large B-cell lymphoma. And of course, those have had a massive effect upon how we approach the management of DLBCL in some territories. Data from the UK demonstrates that we can achieve durable responses, and indeed for those patients who have reinfusion, event-free survival is 40% at 6 months after completion of therapy. And there looks to be a plateau. So this offers a very real option for patients with relapsed and refractory disease. The long-term follow-up data demonstrates that durable responses can just as well be achieved in those patients who have refractory disease as those patients who have relapsed disease, because it presents a distinct mechanism of action that's independent of the effects of chemotherapy. Now, the question is, how do we sequence the CAR T cells and the potential autograft? The superiority of CAR T cells hasn't been proven over stem cell transplantation in those patients with relapsed chemosensitive DLBCL. And actually, over the last few years, we've actually seen a decline in the number of stem cell transplants as patients, as physicians choose CAR T cells over trying to improve remissions and get patients to stem cell transplantation. CAR T cells clearly work post-stem cell transplant relapse, but the reverse sequence isn't generally considered to be feasible. And of course, it's difficult to deliver further therapies for patients that relapse after CAR T cells. So, of course, the strategy at the moment is induction therapy, an attempt at reinduction with second-line therapy with an autograft, failure of an autograft CAR T cells. Now, we have a number of phase 3 second-line studies that, of course, include patients with refractory disease that we are due to hear reported in the coming months. These studies have compared CAR T cells to the standard of care of reinduction chemotherapy followed by stem cell transplantation. And I think, of course, these studies have the potential to really shift our treatment pathways in the coming years. And of course, CAR T cells are becoming open to more patients. We've seen data from the Transcend study that looked at lysocaptogene that included patients where moderate impairment of physiology did not preclude entry into the clinical trials. So this included patients with some impairment of left ventricular ejection fraction, patients with reduced creatinine clearance. And indeed, in the pilot study that looked at lysocaptogene, this examined a group of patients who were older and not eligible for stem cell transplantation or had a degree of moderate organ impairment, and giving CAR T cells to this group of patients in the second line setting was associated with an overall response rate of 89%, a CR rate of 56%, and durable responses. So we can see that in the group of patients who may not be fit enough for stem cell transplantation, they may be robust enough if selected carefully to receive CAR T cell therapeutics. For those patients where the decision is not entirely clear whether they are fit enough for stem cell transplantation or CAR T cells, then reinduction immunochemotherapy is generally offered. The use of R-GemOx, R-GDP is associated with some moderate response rates, but unfortunately the response rates are not durable. The use of polatuzumab, the anti-CD79 directed antibody drug conjugate, in combination with rituximab and bendamustine has shown superiority over rituximab and bendamustine alone in those patients who are transplant ineligible. And I think this data has proven to be very exciting and has really brought this regimen up in the pecking order in terms of our therapeutic sequencing. But I would be cautious about using rituximab and bendamustine combinations in patients where you think you might want to potentially use CAR T cells in their treatment algorithm in the future, because it may compromise the ability to collect sufficient numbers of healthy CAR T cells for induction in the future. Of course, in patients with refractory disease who receive RB-Pola, we see a progression-free survival of some 6 months and an overall survival of 9 months. So there is certainly some value in this regimen. Now, there are a number of new agents that have recently received approvals or at the stages of late phase development. One of those is an antibody drug conjugate directed against CD19, LonCAR-T, which has been looked at in patients with relapsed and refractory diffuse large B-cell lymphoma. In this study, patients had an overall response rate of 48% with a complete response rate of 25% and a median overall survival of some 9 months. We also have a naked monoclonal antibody directed against CD19, tafasitamab, which has been used in combination with lenalidomide. Now, importantly, in the study that was pivotal the L-MIND study in this group of patients, it did exclude those patients who had primary refractory diffuse large B-cell lymphoma, defined as those who've had no response or progression within the 6 months of frontline therapy. So of course, our patient here wouldn't have been eligible for the study. But that said, we see overall response rates of 58% and a progression-free survival of 16 months in those patients who were eligible. And indeed, using a CD19 before CAR T cells is feasible. I think we're all a little concerned that actually you may select out CD19 negative clones by exposing these patients to a CD19 antigen, but actually we can see that CAR T cells can be safely and effectively given after patients have had a CD19 directed therapy. We see the exciting data that's coming out of the bispecifics directed against CD20 and engaging T cells through CD3. They have different routes of administration and they have different mitigation strategies against cytokine release syndrome. But of course, we've got evolving data, and there's no doubt bispecifics will fall somewhere within our treatment algorithms for our patients with relapsed and refractory disease. We've seen effective outcomes in patients who have received bispecifics after CAR T cell therapy. And of course, this has the advantage because chemotherapy is very difficult to give after CAR T cells because of the cytopenias. We've seen data, the use of ibrutinib and lenalidomide in patients with relapsed and refractory DLBCL, which both provide distinct mechanisms of action and may be tolerated in some patients later line who have had multiple exposures to chemotherapy. And more recently, we've also seen the exposure of selinexor, which is a first-in-class XPO1 inhibitor, which is associated with some modest response rates, but actually for those patients who do respond, actually some of these are proven to be relatively durable. So the outcomes for patients with primary refractory diffuse large B-cell lymphoma remain disappointing in the rituximab era. I hope that we can get better at selecting out which groups of patients are going to fail, and perhaps we can intervene early, and that may come through better use of PET scanning or better use of ctDNA. There's still a role for conventional chemotherapy in these patients, despite the wider adoption of cellular therapies. And I think the antibody drug conjugates and the bispecifics offer us some exciting new options for our patients with difficult disease. I think there's a lot to be worked out in terms of sequencing and how we best use these therapies. So I very much look forward to our discussions in the Q&A. Thank you.